Hello, everyone. A very good evening to all of you who's joined today for this second episode of Maitri PregaClinics. Before we kickstart today's session, let me wish everyone a very happy Makar Sankranti, Pongal, Uttarayan, Bihu, all the harvest festivals marking the beginning of harvest in our country, which is celebrated with different names all across the country. But it's one spirit that India unites in, and everyone celebrates in their own way in different ways. So, wishing you a very happy festival season. And I welcome all of you today to this second episode of Maitri PregaClinics. As you know, this is a different initiative that we have started, basically looking at interactions through cases, a case-based learning approach where we have a case presenter who will present a novel case in related to diabetes and pregnancy. And then we have experts who will be taking us through different protocols and different guidelines on how to manage these cases so that we can have a lively discussion and interactive discussion ending up with common protocols with a uniform precision based approach to managing hyperglycemia in pregnancy. We all know we are all in the middle of a pandemic of diabetes and obesity, and therefore diabetes in pregnancy is also on the rise, be it gestational diabetes or pre-gestational. So this is a unique initiative, and we air on every second Wednesday of every month for this episode. Since it was Makar Sankranti yesterday, so we decided to do it today. But otherwise, our routine is second Wednesday of every month from 8 to 9 p.m. India Standard Time. Another novel thing that has happened today on this auspicious day is our affiliation with IDF Southeast Asia. Thanks to Dr. Banshi Sabu, IDF Southeast Asia chair, who actually agreed to allow us to affiliate and reach out to the entire IDF Southeast Asia region to take forward this to the entire Southeast Asia region. So thank you so much, Banshi Sabu sir. I welcome you to this episode. And also, I'm happy to have Dr. Faria Afsana from Bangladesh joining us today as part of the IDF Bangladesh team. And very soon, we will have Sri Lanka, Nepal, Maldives, and all the other IDF Southeast Asia partners joining us for this great initiative. So, before we start, may I welcome Dr. Banshi Sabu, Chair IDF Southeast Asia, to say a few words.
Thank you, Shalini. This is a great initiative. It's congratulations on a
Thank
very
you, sir.
auspicious day when you are starting this with IDF Southeast Asia. I'm really very happy that you started this Prega Talk, and then I'm happy to join from Southeast Asia as a chair, and I could get the people from Nepal, Sri Lanka, and from Bangladesh. I'm very happy that today we have with us Faria from Bangladesh, but I'm sure we will able to have few more people from Maldives, Mauritius, and maybe from other Asian countries like Malaysia and Indonesia. It's really very important because we have this challenge, and then Asian countries, this challenge is common, whether it's from India or whether from the Southeast Asian countries. So the challenges are common. And as you have very, initiated with a case-based discussion, which is very important for clinician to understand. And today case is very, very important with the type 1 and, hyperglycemia and pregnancy with someone with type 1. And we have expert like Usha Sriram, who is treating diabetes and pregnancy, and particularly with pre-existing diabetes since years. So I'm sure every one of us will get a lot of benefits of her expertise. But this challenge is very common across this part of the country. I will be also informing the IDF office that we are starting this and we have already initiated this. And maybe in near future, we will have the Western, other Asian countries, and maybe Western Pacific as well as Europe also to join. This is a wonderful initiative because the idea is to reach out to the people who are in, rural most areas, or they are not in position to join us for many of our national meeting. We know that we do a lot of national meeting, regional meeting, but still it is not possible. And how we can join, my suggestion is if we can join the Foxy and the people from our colleagues who are in OBGY, if they can join also, I think it will be a great benefit to the people with diabetes. That's what my wish is. I'm very happy today that my three close sister, my elder sister Usha Shriram is there with my close sister Shalini and my very closest Dr. Durvi, who is there with this seminar. I'm sorry that I will not be continuing this because of I'm engaged today with some social initiative. Some social engagement is there locally as it's a festival time. But thanking Faria that you could join from Bangladesh, and I'm sure we will able to have Dr. Dina and Dr. Other colleagues from Sri Lanka and Maldives and Mauritius. I'll be contacting them. And thank you, Vipul, for right time. You have reminded me that I could join. And thank you, Shalini, for this great initiative. And I wish you all the best as you are not only a president of DIPSI, that's what a dedicated group for diabetes and pregnancy study in India. But actually, we are looking for this challenge, which is across Asian countries. And I'm sure under your leadership, with your connectivity across Asian countries, we will get people from Middle East. You have very good connection in Egypt. We will try to get the MENA region. We will try to get the people from Southeast Asia, Western Pacific, and we will make a big initiative. And I'm sure during our IDF meeting, where this time IDF meeting is in Qatar, again in Middle East region, I'm chairing, I'm a program co-chair, and I'm sure we will able to get the diabetes in pregnancy is a major challenge in this part of the world. We will have a dedicated symposium also. And we have a dedicated stream also for diabetes in women. So I'm sure you people will do great job and expecting more than 12,000 delegates.
Wow.
And we have a dedicated session definitely in our Diabetes India. This is a big meeting which is going to happen next month on 13, 14, 15, expecting 3,500 delegates from all across the country. And people from different parts of the even neighboring countries are also joining. So I wish that most of you will be there, and I welcome you all for that Diabetes India meeting. And once again, thank you, Shalini, for giving me this opportunity to share the dais, particularly with Usha Sriram. And you considered me as one of the expert. That itself is proud moment for me, Along with Usha Sriram, you invited me, but I'm really thankful for that. And thank you once again for giving this opportunity. Thanks, USV. PSG Group, who joined along with you, and Dipsy and all other associates who are part of it. But I'm sure IDF Southeast Asia will continue to work with you, and we will take this to the even International Diabetic Federation also. Thank you. Once again, thank you very much.
Thank you so much, sir, for your kind words and so much support and encouragement. It's really motivating when, seniors like you are there to inspire us and motivate us. And I'm sure with your support and guidance, we will definitely take it forward to across the borders. Thank you
Thank
so
you.
much, sir. Thank you.
Thank you. Bye
Thank you, sir.
bye.
Thank you, sir. Bye, sir. Thank you.
Thank you.
Thank you.
Bye. So to kickstart, let me introduce our experts. Dr. Usha Sriram, we all know her so well, founder Divas, a woman who leads from the front when it comes to diabetes and women, and somebody who's really passionate about pregnancy, preconception, and everything related to, women's health, especially when it comes to preconception, during conception, post-conception. And we've been working together for such a long time, and I'm so happy that we're at least able to create that kind of noise and get some kind of people sitting up and thinking. And that is why I think Prega Clinics initiative becomes all the more important, because this is where we will be having a lot of multi specialities, cross specialities, obstetrician friends, nutritionist friends, a lot of people coming in with their inputs, because it's not only about getting pregnant and delivering a baby. It is all about, right from the beginning. I think right from adolescence, preconception starts right from adolescence. And then all through the pregnancy, post menopause, also we'll be discussing how things can, run and impact a woman's health till then. So thank you, Usha ma'am, for joining us today as our expert. And we're honored to have you with us. We're also honored to have Dr. Faria Sana from Bangladesh, who's a renowned endocrinologist, somebody who's very active on the international scene, and again somebody who works a lot in women's health. Thank you, ma'am, for joining us, and I invite you to be part of this meeting as an expert today. with all your inputs during the case discussion. To present this case, we have Dr. Thank you, ma'am. So to present this case, we have Dr. Amala, Dr. Amala, Florida, a renowned consultant diabetologist from Chennai, who's again actively working in the field of diabetes and women. And she will be presenting a case of a woman with type 1 diabetes and take us through her journey of pregnancy with type 1 diabetes. So the stage is all yours, Dr. Amala. We'll request you to present the case. And I'll request our experts, Dr. Usha and Dr. Faria, to you can stop her anywhere if you have any inputs, any questions, any important points that our audience will probably, highlighting on some important aspects of management and where things could have changed the trajectory, where things could have probably been handled in a different way with all your inputs. So this is an interactive discussion, an interactive case-based approach. And before we start, we do have a lot of partner organizations with us. CMRE, Dr. Rajiv Chawla and me, both of us, we part of CMRE, Consortium for Medical Research and Education, again, a foundation that looks into all the different academic programs that we do together. Dr. Chawla is indisposed today, so he's not able to join. He'll be there for the next session, and he's the IADPSG representative of DIPSI on the international platform, and a co-program Sutradhar with me. We also have PSG India, headed by Rutul, as part of our partner. We have AOGD, an obstetrician organization from Delhi with Dr. Piki Saxena as our partner for this program, and of course, DIPSI. My own organization, as president of DIPSI, this was something that I always wanted, to take pregnancy to the grassroots so that we all have a uniform approach when we manage our patients with diabetes and pregnancy. So I welcome you, Dr. Amala, to start presenting your case, and then we'll take the discussions forward.
Thanks, Dr. Shalini. It's indeed a privilege to present this patient in this forum, since it's dedicated for pregnancy in diabetes. So I'm a colleague of Dr. Usha Shriram. So I've been working with ma'am for the past 7 years. So as soon as ma'am was discussing about this upcoming Prega clinic, so this patient immediately sprang to my mind, because she has been under our treatment since 2022. And she is really a landmark patient to us, because she lost follow-up with us. She came back to us, and throughout her pregnancy, she was under our follow-up. The outcome was really good. So I just told ma'am that I'm going to present this case. So ma'am was also happy about it. So let's go into the case presentation.
Can you share your slides, please?
Yeah.
Can we have her slides on the screen?
Yes, sir.
Are the slides?
Yeah, my slides are visible, right?
Yeah, they
Yes.
are visible. Yeah.
This patient is Ms. Shwati. Actually, she had presented to our department as a 19-year-old adolescent in February 2021. So since she was diagnosed at her age of 13 years with type 1, but she was getting treated in a government sector hospital. So she was under very irregular treatment. She could not go for follow-up there, and she came to us with very uncontrolled sugars, actually. So when she presented to us in 2021, she had severe osmotic symptoms, and her HbA1c was way high. It was 16.6. So once she came under our care, her HbA1c started settling down, but she had a very turbulent treatment course. Like she had recurrent admissions. She used to skip her insulin. She had a few family issues, because two of her siblings were special children. So the mother was a single mother, and she could not cope with all these challenges. So she had a very poor social support. In spite of that, she was just managing, and she was getting recurrently admitted for DKA, since she used to skip insulin a number of times. And one particular issue which was a big challenge for us when managing her was she had a very severe gastroparesis. she used to get admitted with severe bouts of vomiting. Even after the DKA settles down, the vomiting used to be there and with severe upper abdominal pain. So we involved the surgeons. They did an endoscopy and found that the gastroparesis was really bad. So then we somehow we managed her, and with recurrent admissions and aggressive PPIs and all that, her gastroparesis sort of settled down. And then hypothyroidism was also diagnosed in 2022, and she was put on a dose of Eltroxin of 37.5. Till 24, things were pretty okay. She was under regular follow-up with us. But then she lost follow-up for nearly 1.5 years, and she suddenly presented to us in July 2025. So in between, she got married. Of course, it was a love marriage. So she had gone away from her home, lost touch with her parents and all that. And she turned up with her husband in July 2025. She was pregnant at that time. She had got married in April 2025. So when she came to us, she was pregnant with 16 weeks amenorrhea. But luckily, her HbA1c was 6.8, which made us really happy. I mean, we were not very much alarmed because her HbA1c was sort of okay. Actually, she was on a very irrelevant insulin regimen. She was on a very erratic mixed insulin. She had gone for hypos a few times and was hospitalized for that. So when she came to us, her HbA1c was 6.8. So we put her on a basal bolus regimen with Fiasp and Levemir, and then we had to switch over from Levemir to Tresiba due to non-availability and all that. And then her anomaly scan was uneventful, didn't show any significant anomaly. Her TSH climbed up to 6.75, so we had to increase the Tyronorm dosage to 0.25 mics. Actually, she had a very supportive husband. I really admired the girl's husband. He was quite pretty regular in bringing her to the OP. They were very regular with the self-monitoring of blood glucose, taking insulin, all sort of things. So every week they used to come for follow-up, and her sugars were well under control. And then she presented to the OG department with sudden onset of labor pains at 38 weeks of amenorrhea. So OG department, they decided to go ahead with an emergency LSCS. Her sugars were quite high at that time, so she was started on insulin infusion. So the baby outcome was really good. She delivered a live male baby weighing 3.02 kg. Baby had hypoglycemia and was treated in the NICU. And on 5th postnatal day, baby was shifted to mother side. Baby was doing good. So we discharged her on a basal bolus insulin regimen. She promptly presented to a clinic after a week after getting discharged. She came back with very well controlled sugars. So she's still on a basal bolus regimen with Fiasp and Tresiba. But from perspective of gestational weight gain, her pre-pregnancy BMI was 28.7. She had gained around 17.3 kgs of weight at 38 weeks of gestation. So this was one area where she could have weight gain could have been a little lesser than what she had gained. So she is still under regular follow-up with us. We have asked for a repeat HbA1c. So she is due to come to our clinic next week. So this is the full case summary. Over to ma'am.
Thank you, Dr. Amala. I think this was an excellent case with so many different points for discussion that we can have. So if we can go to your first slide. I mean,
Yeah.
she presented to you as a young girl with type 1 diabetes, uncontrolled, multiple recurrent episodes of DKA, initiated on basal bolus regime, and the A1C started settling before she actually was lost out. So
Yeah.
here, if I may, I think this is where the importance of preconception counseling to young girls comes in. Usha ma'am, I would like to have your inputs on this.
Thank you, Shalini. First, I want to congratulate you for doing this. I think this kind of a real world clinical scenario based education is so important in diabetes care. I'm so glad that you're doing this, particularly in pregnancy where there is so much of diverse opinions, myths, misconceptions, debates. So I think this is great, and congratulations on doing this.
Thank you, ma'am.
And coming to type 1, just another minute of introduction. I mean, the landscape has changed. There was a time, let's say 100 years ago, when women with type 1 diabetes first didn't live that long. And having a pregnancy was like a miracle. And then, going through that pregnancy safely and delivering a baby is an even greater miracle, something that did not happen. And once insulin came, into existence, slowly that scene started changing. But now I think with the kind of tools that we have, home glucose monitoring, CGM, hybrid closed loop system, and all the different kinds of insulins and medications and surveillance we have, we really can actually, provide very good care for these women. But I think you hit the nail on the head, which is we need to get them ready for a pregnancy. And that's, if you want to think about it, it's called a one key question. So not only do we have to ask women, let's say who are married or who are sexually active, what are their reproductive plans? But generally what we need to do is, start from the time they attain puberty. It may sound too early, but then there are lots of people, young girls who may have, teenage pregnancies unplanned, or they may, many young women in South Asian countries get married early. So we need to start talking to the parents and about the importance of preconception care, which is actually not something very invasive or anything. It's just a matter of getting things under control, making sure that they're on the right medications and not things that are, cannot be used during pregnancy, and making sure their end organs are, checked frequently so that they're ready. We come to this discussion of gastroparesis, but before that, Dr. Amala had talked about this girl's siblings being, special children, single mother. So the social determinants of health, childhood, economics, education, the built environment, the home environment, all of that plays an outsized role in diabetes care, type 1, type 2, everything. And particularly this, and in girls especially, many of them, like Amala was saying, that this girl would get into frequent DKAs by omitting insulin.
Yes.
Well known that they do this for a secondary gain or some sort of emotional, maybe getting into a hospital or things is attention seeking also.
Absolutely.
Well
Agree.
known that girls can get DKA by omitting insulin, either because of that or even weight issues. Some girls who are overweight will skip it so that they will lose some weight during the time that their sugars go up during the osmotic symptoms. Anyway, that social determinant of health is a very critical thing in type 1 girls. She lucked out with her partner, her spouse, who's a very supportive husband and helped her through the pregnancy. But preconception care, every time, every opportunity we have when we meet a girl with type 1 or type 2, and with the parents, we need to keep talking about, give us some time, give us 6 months to 12 months to get her ready for the pregnancy, because there's a paradigm shift now in the way we think. A healthy girl becomes a healthy woman, and then she becomes a healthy mom.
Yes.
Suddenly, one fine morning, you can't wake up and be a healthy mom.
Absolutely.
You have to go through that stage, right? So, for the first slide, definitely, this is what first part of the presentation. This is what I want to add, and discussing contraception is a touchy subject, sticky subject. How do you talk to one of our South Asian girls, especially if they are single, about contraception? But we have to. In the most, what can I say, careful and sensitive and diplomatic way. We have to find out if they're sexually active and also talk about contraception, because an unplanned pregnancy so dangerous for their own health and for the health of the baby.
Absolutely. Absolutely. So important. I mean, this is such an important discussion point and a very important take-home point, I think, for all the audience who's logged in today. Preconception counseling has to start in all adolescent girls. Don't assume that you want to counsel them only, once they're married and they come to you and tell you that they're going to get pregnant, because many a times they'll be lost to follow up, they'll get married, and they come to you only when they are pregnant. Luckily, this woman, even despite being lost to follow up, came at 16 weeks with an HbA1c of 6.8, but that does not happen so often. So many times we will see women coming with an unplanned or an accidental pregnancy, and the A1Cs are all over the roof, 10s, 11s, and 12%. So I think an important take home point is preconception counseling, telling them very clearly what the risk of an unplanned, uncontrolled diabetes pregnancy can happen. So I think the risk of congenital anomalies has to be explained very clearly. The need for achieving an HbA1c target of anything between 6 to 6.5% before they get pregnant is very important. A planned pregnancy where you need to give them folic acid even before they conceive is so important to prevent the neural tube defects. So I think we all need to have that checklist of preconception care, the different steps. Suppose she's on ACE inhibitors, she's on a statin, all those have to be taken off the prescription. These days for weight loss, we are giving GLP drugs. I have come across where off-label in type 1s also GLP-1s are being given, especially in those who have obesity as well. So GLPs have to be stopped at least 2 months prior to conception. So I think a checklist of the do's and don'ts before they plan a pregnancy should be explained to them at every visit for every woman who has diabetes, who has a potential of becoming pregnant in the reproductive age group. This is very important. She may not even be planning, and then she comes with an accidental pregnancy. So I think as doctors, it is our responsibility to tell them that if your glucose levels are not under control, if your A1C is more than 6.5, it could be a huge risk to not only you, but to your baby. So I think telling them to plan a pregnancy, putting them on folic acid, stopping ACE inhibitors, stopping statins, converting them to safer antihypertensives, doing a microvascular complication screening, right from retinopathy to nephropathy to neuropathy, all these things are very, very important for preconception. Dr. Faria, I would like to bring you in here. How is the scene of preconception counseling in your country, in your region? And do you also have a similar presentation? Because we're all the same ethnicities, I think. So we have common problems. So how is your experience?
Thank you. Thank you for asking me to join this wonderful program. And thank you, Dr. Amala, for beautiful presentation of a very rare case, I will tell in that way, because it is very well managed, well planned, though not properly planned. But in our scenario, actually, this type of patient is very rare, I will tell, because it happens that without any preconception, there is pregnancy. They are not at all aware of the preconception counseling or preconception planning. But we have some projects to do some help for these with the marriage registers trained about the counseling, about the preconception care. They just say few words and distribute a leaflet during the marriage registry. And though the couples are not so much interested on that, but actually the guests present there may have some knowledge in their mind that there is the importance of the preconception care. So it is gradually improving day by day, but there are a lot of rural areas where preconception, even antenatal care is not so much popular. So preconception care is not so much nowadays, but actually it is very, very much important, especially for this type 1 diabetic patients, this preconception care. In our scenario, type 1 diabetes is very small in number, but Actually, they are not properly taken care of about the all the things. And among the type 2 also, the rural areas, they are actually not dealing with all the problems, the importance, the knowledge about the importance of reducing the HbA1c. They actually think, let us take the oral agents, think about the insulin after I get pregnant. That is a very important thing for for counseling, because it is not the time to start insulin after pregnancy, but stop the oral drugs at least 3 months. Make that HbA1c target. That is the important thing. Many patients come with us stopping the drug after the pregnancy test is positive. That is a very common scenario here. So that is another point of education, as Usha ma'am was correctly saying about the from the adolescent period at the time of diagnosis, either type 1 or type 2, each and every girl or woman should be educated about the preconception and the reproductive age planning.
Absolutely, ma'am. I think this is very, very important. Dr. Dhruvi, are you there? I think she raised her hand. She had a question. Dr.
Yes,
Dhruvi?
ma'am. Yeah. I'm
Yeah.
here, ma'am. So it's a very wonderfully managed case. Congratulations, Dr. Amala ma'am, for doing a wonderful job with the girl over here. Hi, Usha ma'am. What I wanted to ask to everybody present here was, how do you manage the mixed transition? There are so many type 1 girls who are with us on basal bolus regimen. They go off somewhere, they are put on mixed again twice in a day. They come back to us with a worsened HbA1c. You put them on basal bolus again for the pregnancy and the preconception planning, and again they go to the gynecologist. They are again recommended premix regimen. How do you tackle this scenario?
I think, Dhruvi, you've raised such an important point here, because this is something that from this platform we should clarify to everyone who's logged in today. For type 1 diabetes, I think a mixed start twice a day or even thrice a day is something that is completely off the limits. So
Right.
basal bolus has to
Of
be
course.
the only prescription for type 1 diabetes, even
Mhm.
before pregnancy, even during pregnancy, even after pregnancy, lifelong. I think the
Mhm.
message should be very clear: no compromise when it comes to choosing the insulin therapy for type 1 diabetics. Of course, for type 2, yes, any of these insulins preconception will be fine, but during pregnancy, again, because of the tight targets, a fasting to be between 70 to 95, and a 2-hour post meal value has to be between 100 to 120 all through pregnancy. And with an insulin like Mixtart, it becomes completely very, very difficult to achieve. So I think this is a very important point, and I would like Dr. Amla or Dr. Usha to give us your inputs on insulin use, insulin therapy A in type 1s and then in pregnancy.
Insulin therapy in type 1, I mean, really, you can use any insulin, depending on financial things. And see, for example, we would ideally like to mimic physiology, right? So nothing like basal bolus. Taking a basal insulin at night, which will help for the fasting glucose also, and then adding a short-acting analog as prandial insulin, which also gives us a lot of latitude to fine-tune, would be great. For example, if somebody is ate a little less, they can take a little less. So they have all those things, and it's so quick acting. It can even be taken after a meal. So if someone's intake is not very predictable, they can even do such a thing. So this would be the super ideal regimen. But depending on their work schedule or their travel schedule or finances and so many other things, we may have to adjust it in such a way that it's either like a 2 or 3 times a day injection with. So someone who's not pregnant, where we want good control, but we are not aiming for this kind of perfect type control, we may be okay with other instruments. But the moment there is either a reproductive plan or see, one more point I just want to bring here is we have this habit of telling people, let me know as soon as you get pregnant. feel or numb, because usually in our country there is an obligation to get pregnant as soon as possible for most women. So this opportunity for us to change the insulin, change the medications, as Shalini has mentioned, tweak the dosage, all of those things can become very difficult. So it should be actually started. I say brides to be, even few months before, start all this process and get things in order. But once they are either planning a pregnancy or they come to us with their pregnant, they really should be on basal bolus, because that's the only one that will give us that kind of a control to adjust their insulin. The recommendation is to use things like Degludec or Detamar, and we can use agents like Asphalt. This probe, things like glutathione and glargine typically are not FDA approved, though the FDA says if a woman has been on glargine, can continue the same insulin, because we do not want to lose control by changing it. So all these insulins are approved, and actually nowadays with the change in pricing, not a huge difference between analogs, and so I think it's important we give them the benefit of doubt.
Absolutely, ma'am.
How do we convince OB/GYNs? That's whenever we are as a team taking care of the patient, we have to establish a Lakshman Rekha saying that we will take care of the insulin and all of those things, and they have a big job of taking care of the mother's pregnancy care and baby surveillance and all that. So this is less of a headache for them.
Absolutely, absolutely. Another very important thing that came out in this case was uncontrolled thyroid. She was 16 weeks
Mhm.
and her
Yes.
TSH was 6.7. So here, any
Mhm.
one of the experts, your input on why thyroid can also be a potential problem. So the focus should not only be on glycemia, but on TSH management as well. Dr. Afsana, if you could shed some light on thyroid in pregnancy.
Yes, of course. Of course, in the preconception and also in the antenatal care, and of course in the type 1 diabetes, when it is first diagnosed, then also the thyroid screening is very much important. And as he missed the first 16 weeks of diagnosis, I think that is the time where it should be done earlier. Though I think it was not previously done, or otherwise it may be normal. But it is the crucial period, the first 20 weeks, when the fetal thyroid gland is not working. So totally dependent on mother. So it is very much crucial to do the thyroid function test and to attain the trimester specific TSH for each and everyone. That is very much important for avoiding the congenital anomalies. And
Absolutely.
regarding the previous discussion on the insulin, and we have we actually practice some basal bolus is not always affordable for all of our patients. No? Then in that case, the split mix or self-mix insulin with the short and intermediate acting insulin is very much practiced in our country also. At least 3 times short acting or 1 or 2 times intermediate acting may be a modified basal bolus for the
Absolutely.
considering the price of the insulin that is
Absolutely.
practiced here.
Exactly, exactly. I think, see, end of the day, all that we want is to have a good glycemic control. So even if it means,
Mhm.
2 shots of intermediate, maybe, and
Mhm.
3 shots of the short acting, I think that would
Short acting.
definitely do the job.
Mhm.
Rather than, just using Mixtard twice a day. I think that is
Yes,
something
yes, that
that
is
we
not
should
a very
always
good
courage.
option.
Absolutely,
Actually, for
absolutely.
type 1 diabetes, Mixtard is not a very good option.
Not
Not at all an option.
Absolutely, absolutely. Yes, exactly. So that should be very clear to all the people who are listening today. For type 1 diabetes,
Mhm.
Mixtard is not an option. It has to be basal and bolus, or like Dr. Faria Afsana said, maybe intermediate insulin twice a day, because it will give them a curve
Mhm.
of 12 hours plus 12 hours, and then 3 shots of the short acting insulin.
It's short
That
acting
will
insulin.
probably give us the same targets. Another important thing that came out was gastroparesis in this woman. Dr. Amala, so did that also have an impact on the pregnancy in any way? Did that cause a problem? Because we know, we have a comment from one of our audience, Dr. Ajay Gupta, who tells us that pregnancy alters gastric emptying and sensitivity. And in India, cultural fasting like festivals worsen the risk. Type 1 diabetics are ketosis prone, and this is where, euglycemic DKA can also be a very important this thing. So how do you manage all that? If I
Yes,
can
Dr.
have,
Shalini, like I told you earlier, she was a very lucky girl actually.
I
Uh,
know. I
in
mean, she
many
was
ways,
extremely lucky to not have any of the problems that we keep
yeah,
hearing.
in many ways. The gastroparesis was a problem when she presented to us as an adolescent, 19,
Okay.
20 years and all
Okay.
that. So luckily during pregnancy, that part was totally uneventful. So she didn't have any issues with that. She didn't even have a mild like regurgitation or any of the APD symptoms. She didn't even complain to us even during a single visit. So in that aspect, she was quite lucky actually, I should say.
Absolutely.
If I
Yes,
may
ma'am.
gastroparesis is, I've talked about this with Dr. Amala. Typically, gastroparesis is a relative contraindication for pregnancy.
Yeah.
It can really, and like, again, the lucky girl, this can cause a lot of problems, everything from severe hyperemesis like symptoms, severe refractory vomiting, recurrent hypoglycemia, nutrition issues, the baby's growth can be affected. So many things can happen in women with gastroparesis. And in terms of medications, again, the options already we have are few, like clopramide and erythromycin and some other prokinetics. So some of them, we may not be able to use that freely during pregnancy. So it's a relative contraindication. If somebody has gastroparesis, must see, actually they say we need to have something like a tumor board like meeting where the specialists sit together and actually discuss the patient and decide is pregnancy a safe option for the woman. Otherwise, they can get into very serious issues. And even her, I want to point out, see, she had a lot of hypos, and her good looking A1C need not necessarily be good. It may
True.
have been
Absolutely.
Yes, yes.
Yeah,
Mhm.
SEGMS might bring it out.
so, which is why
Mhm.
at this point that in women with type 1 after the concept study and others, we know CGM is a very good tool if we can afford it, and validated by an SMBG, or at least definitely SMBG should be done, because the time and range has to be there, and they've shown with CGM you get a slightly better time and range, a slightly better A1C, and slight improvement in baby weight and things like that. So CGM has become a boon, and of course closed loop hybrid, the insulin pump. If somebody should have this kind of like gastroparesis or serious complications, that would be an ideal patient.
Absolutely, ma'am. One important thing that again is very important and birth discussion is gestational weight gain. 17.3 kilograms weight gain. Your comments, ma'am.
I want to say I'm ashamed to say that she was under our care, because we should not have allowed that. But then, the reason is for pre-pregnancy BMI itself was very high. 28, Amala? Something like
Yes,
that.
ma'am, 28.1.
Ideally, she should have been allowed only like 8 kilos, somewhere in that ballpark. You don't want weight loss, but not a big weight gain, right? But then um, uh, we can keep reinforcing every visit. We can keep asking her to meet the dietitian. We can talk to them. But there is so much of other socio-cultural influences when it comes to women and pregnancy and eating. They have grandmothers and mothers and other people and mother-in-law who keep telling them, I didn't do such a thing. You have to eat a lot during pregnancy, and she didn't have except for a nice good husband, maybe she didn't have the right kind of advice at home. But she definitely should not have gained that much, because that's what can I say, a real red flag, and could have caused major complications for her. Because look at the baby weight; it's like 3 something.
Yes, it was, I think, a 3 kgs, 3.02.
Baby's weight is 3.02 kgs.
Three is perfect. Three is absolutely spot on, perfect. But with this kind of weight gain, easily hypertension risk could have been higher. And by the way, speaking of hypertension risk, women who have type 1 diabetes from 12 weeks of pregnancy should be on low dose aspirin.
Aspirin, absolutely.
Very, very important to decrease the risk of hypertension. They need to be on higher dose of folic acid, 5 milligram as opposed to the usual 400 milligrams. 5 mg as opposed to the usual dose of 400, because they have at much greater risk for birth defects, anomalies, especially neural tube. So women who have diabetes, women who have a previous history of neural tube defect, all these people, or who are on some sort of anti-folate medications and stuff like that, should really be on this 5 mg dosage. So that's another important point in these women. And so this weight gain would have amplified all those risks.
Absolutely, absolutely. I mean, this was absolutely sheer luck that with, uncontrolled diabetes, thyroid way too high, so much of gestational weight gain, and, she, first 16 weeks, she did not turn up. I mean, she was not there under your care. So, the congenital anomalies, no folic acid, everything. I mean, this was probably, very lucky woman.
Luckiest pregnancy.
Absolutely, absolutely, absolutely. So another important thing, neonatal hypoglycemia. So where is the neonatal hypoglycemia risk high, especially in women who are taking insulin, especially high doses of insulin in their pregnancy, and how can we reduce that? Any one of you
Mm,
can take that question.
I think the or peri-delivery or labor time glycemic status of the mother, that is a very important thing. Very strict control at that time actually reduces the hypoglycemia of baby, because uncontrolled, everyone we know that this uncontrolled diabetes causes increased blood glucose flow in the baby and increased pancreas, stimulate the pancreas to secrete insulin, and when the placenta cut off, then there is increase in insulin but no glucose supply for the first few hours or few minutes. In that case, there is chance of hypoglycemia. So if mother's blood glucose is strict, very strict in the pre-delivery time, in that case, due to low supply in the glucose to baby, insulin is also not stimulated and there is less chance of hypoglycemia. So pre-delivery blood glucose or glycemic control, if it is very in strict control, then it is very much, we can very much able to avoid this hypoglycemia, neonatal hypoglycemia.
Absolutely. I think that is again a very, very important aspect of managing a type 1 diabetes pregnancy. I think so, it's right from preconception to antenatal monitoring to postnatal and postpartum. We have a question from the audience on breastfeeding alters insulin doses. So, how do you manage your insulin doses during breastfeeding? How do you manage hypoglycemia risk during breastfeeding? So, Dr. Amala, if you can shed some light on breastfeeding in type 1 diabetes and insulin dosing, and how do you manage, how do you avoid hypoglycemias? Breastfeeding is a very energy intensive process. So, telling mothers not to, breastfeed on an empty stomach.
Yeah. Yeah, ideally we ask them to take the bolus dose of insulin after breastfeeding, after feeding the baby actually. So that would minimize the risk of hypoglycemia. So that's one precaution that we say. And even mothers who are on metformin or sort of OHAs, even taking that medication, we ask them to do it after the breastfeeding. So that's one precaution that we give them to avoid hypoglycemia.
Just wanted to add that it's very, very important to first encourage breastfeeding. 6 months of exclusive breastfeeding and about a year or year and a half of complementary breastfeeding. Super important because breastfeeding improves insulin sensitivity. So the mother's insulin requirements will come down, will facilitate weight loss, and besides all the other benefits of breastfeeding. So it's very, very important to encourage that. And secondly, as Amala said, timing of breastfeeding and the intake of the insulin, encourage them to eat a snack to, when they finish breastfeeding and they're going to take the insulin or before they breastfeed, take a snack and then take the insulin. And that also is very helpful. As soon as the baby is born itself, within a few hours by next day, the insulin sensitivity starts improving considerably. So their insulin dosages that
Requirement comes.
pregnancy would come down. So we need to be cognizant of that and heighten the home glucose monitoring or have a CGM so that they can come to a decent insulin dosage quickly. So usually people don't get into severe hypoglycemia because they breastfeed if they take a snack.
Yes. I think that is very important. A snack before they feed the baby is also very, very important to prevent hypoglycemia during lactation. So I think we do have a lot of comments and questions, but due to paucity of time, we'll probably have to wind up. There's so much to discuss more when it comes to type 1 diabetes and pregnancy. But before we end, Usha ma'am, a quick checklist from your side for everyone who's logged in today. A girl with type 1 diabetes, planning pregnancy, 1, 2, 3, 4, 5, 6. What are the important things that you need to start before she gets pregnant, and then throughout conception, some important key highlights that we should keep in mind?
Thank you, Shalini, for this opportunity again, because this message is so important. So first one is glycemic control. You just put them in different buckets. Glycemic control, want an A1C 6 to 6.5, but it can be less than 7 if they are hypoglycemia prone. So this is number one. We want to reach that A1C goal by putting them on as we discussed, the right kind of insulin and also with the right kind of home glucose monitoring. And we know that it will take a good 3 months, 4 months to reach that A1C or even a little longer. So that's why I said they need to give us a good 6 months time or even longer, preferably little longer, to help us to facilitate this. So that's glycemic control. Number 2 is hypertension. If they have hypertension, they should not be on ARBs or ACE inhibitors. The ideal drugs are labetalol, alpha-methyl dopa, and calcium channel blockers. So we need to change it to that. And at 12 weeks of pregnancy, we put them on low-dose aspirin. This is for hypertension. Then comes dyslipidemia. Statins were banned at one time, or there was a black box warning. Recently, the black box warning has been removed. So they say you can give statin for those with like a homozygous or a heterozygous, familial dyslipidemia who has very high lipids. You can give for them. Other people, we discontinue. Then comes end organ damage testing, eye checkup, kidney function test checkup, and then somebody like this with gastroparesis. And then now something very important. Lots of women are older. And so if they are older than 35 or they have diabetes more than 10 years, they should get cardiac checkup. Very, very important.
Yes.
So testing should be done. Then comes folic acid, like I mentioned. You can give for 5 and not the 400 milligram dosage. The higher dose of folic acid should be given. All their vaccinations should be brought up to speed because you cannot take vaccinations at least for 1 or 2 months before the pregnancy. So all of them should be completed. Things like rubella if they've not taken it, and other vaccinations that suppose they've taken 1 dose of HPV, they have to complete it, wait, and then only get pregnant. So that has the vaccination part has to be attended to. Then comes this whole weight thing, nutrition. So if they're underweight, we need to bring up their weight, nutrition, and so the right nutrition during pregnancy should be emphasized. If they're overweight, any amount of good weight reduction prior to the pregnancy is going to be so beneficial in decreasing the risk of all the preterm delivery, hypertension, all the other complications. And especially for baby now, we are now talking about birth defects. Weight alone is increasing the risk of birth defects and neurodevelopmental issues like ADHD and learning disability and autism spectrum and all that. And I didn't mention first in the glucose control. See, women come to us 7 to 8 weeks after they've missed a period. By then, the window is closed.
Yes.
Most major organ developments are done.
Yes.
That's the reason why telling them, come to me when you're planning a pregnancy, come to me after you get married, all that doesn't work. We have to keep on emphasizing this, as Faria said, from early on, so that this is something that's in there. And lastly, about things like thyroid and vitamin D and all that. Thyroid, definitely, all people with type 1, even if they don't have a thyroid problem, should be checked and treated. And their TSH brought to either below 2.5 or now people are talking even better, like 1.5-ish. You can bring it down and keep it perfect. So, and then if they have any mental health issues, which many girls with type 1 have, and since stress itself is now considered a teratogen, we want to make sure that they are prepared, they have a supportive environment, family, for them to take these things. A lot of it just depends on awareness, because in our department we are doing a lived experience study on women with diabetes and pregnancy. The standard answer to most questions, I didn't know.
Yes.
I didn't know. I don't know. I didn't know. Is the standard answer. So it's also our moral responsibility to tell them all these things in the gentlest, most unthreatening way, of course. So this is how we get the girls ready.
Absolutely. I think this is so important. All the different aspects of preconception counseling and care that should be part of our regular treatment protocol for all young women or young girls with type 1 diabetes or even type 2 diabetes who come to us. The only difference is in type 2 diabetes, you need to stop the oral drugs 2 to 3 months before they get pregnant, So none of the oral drugs is safe in pregnancy. Metformin, yes, now has an indication, but you should know where to stop metformin and, in case there are some contraindications to metformin. That's a topic for another day. Just a quick question, ma'am. There's a question from the audience, Dr. Jitendra Kumar Patel, who asks, should aspirin 75 milligrams be started preconception or at 12 weeks? I think it's very clear, 12 weeks. What about clopidogrel in type 1 diabetes already before conception? Do we need to stop clopidogrel?
They should be, those are all the very important reasons why they got put on it. Suppose they have it's an older woman with a stent or a metal stent, or so in consultation with the cardiologist, that has to be done. One last thing, if I may add, no woman with diabetes, however poor her control, A1C could be 16, is an indication for termination of pregnancy. We can get them under good control. We can do fantastic anomaly scanning. We can do fetal echocardiography. And we do all this quadruple scanning for the Down syndrome. Only but we tell them, if we find something majorly wrong, that is, let's say, not compatible with life, or they decide not to proceed, we can always do it before 20 weeks. But we don't have to, advise termination for anyone. Faria, I don't know what you.
Yes, yes, of course. Because actually, whatever the evidence or guideline recommends, but as we see, though there are very much uncontrolled diabetes, but do not have so much anomalies or so much things. So it is not judicial to terminate to our counsel for termination. Because without any complication there may be some anomalies also, so how we can prevent that? In that case, I think as we are also practicing here, and my personal opinion is not to ask for termination, try to achieve the target as soon as possible. That is the important thing.
Absolutely. I think we've had a great discussion today, and I think a lot of doubts have been cleared when it comes to type 1 diabetes and pregnancy. We've had great inputs from our experts, Dr. Usha Shriram and Dr. Faria Afsana. It's been a pleasure to have both of you as our experts today, and all your inputs have been so valuable to us. And Dr. Amla, thank you so much for this great and very interesting case. Hats off to you for ending up with a woman who's delivered a normal weight baby, a 3 kilogram baby, because there were so many things against her, right?
Yeah.
From, poor follow ups, uncontrolled diabetes, wrong insulin regimes, which were not really indicated for a woman with type 1 diabetes, and that too in pregnancy. No folic acid started before pregnancy because she's come to you at 16 weeks. So she's just been extremely lucky to,
Yeah, gastroparesis.
gastroparesis, uncontrolled thyroid. So I think anything that could have gone wrong anywhere, and so much of
Exactly.
gestational weight gain.
Yeah.
Neonatal hypoglycemia, probably anticipated with so much of insulin that she's taking. So maybe
Yeah.
I think this was a very
He has bet
interesting
all the
case.
odds.
Yeah, and God had been kind probably to this lady that finally at 16 weeks she was able to make it to you. So,
Correct. Exactly.
so thank you so much,
Thanks,
everyone, for
Dr.
logging in
Shalini.
today. And it's been a great case. And thank you so much, our experts, Dr. Usha Shriram ma'am and Dr. Faria Afsana ma'am, for joining us today. A big
Thank you.
word of thanks to Dr. Banshi Sabu, Chair, IDF Southeast Asia, who's connected us to the entire Southeast Asia region. And on behalf of all my affiliates, as DIPSI President, I would like to thank all of you for joining hands with us in taking our mission forward on talking about different aspects of diabetes and pregnancy, gestational diabetes, type 1, type 2, and we have a lot of discussions lined up. We'll be covering all these topics one by one. Thank you for all the delegates who've actively been logged in and asking questions, giving us their comments. I'm sorry, because of paucity of time, I'm not able to take each and every comment, but I think we've had great interactions with our delegates who logged in, and I'm sure on behalf of Dr. Rajiv Chawla and my conveners, Dr. Dhruvi, Dr. Vipul, Rutul, and Dr. Rami, I would like to thank everyone who's logged in, and I welcome you to join us in February on the second Wednesday of February, again 8 to 9 p.m. for our third episode, and we'll bring you another very important aspect of diabetes in pregnancy. We'll have our obstetrician colleagues also joining us, and therefore I close this session today with gratitude and thanks to one and all, and welcome you to join us on the 4th of February for our next episode. Thank you so much.
Thank you.
Thanks,
Thank
Thank
thanks,
you.
you.
Dr.
Thank you,
Shalini.
Dr.
Yeah.
Usha. Thank you, Dr. Faria. Thank you,
Yeah,
Dr.
thank
Amla,
you
for
for
joining
Thanks,
us.
inviting.
Dr. Shalini.
Thank
Yeah.
you.
Bye.
Thank
Thank
you. Good
you.
night.